Let's go to another case. The second case will be presented by Dr. Carla Granja. Dr. Carla is a Master of Surgery at the University of São Paulo and member of the Brazilian Society of Esophageal Motility and Neurogastroenterology. Thank you, Carla, for your participation here.
Thank you very much for the invitation. I'd like to congratulate the professors for the brilliant exposures before, and let's see the case. Can you see the case, the exposure?
Yes, Carla.
Yes.
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 Thank you. Thank you. The case in June of 2018, 56-year-old woman was referred by a surgeon to our digestive motility service for a preoperative evaluation of bariatric surgery. At the time, the patient had a body mass index of 42.9. As a comorbidity, only arterial hypertension, and at the standard questionnaire of our digestive motility service, she reported heartburn related to eating sweets and fats, and denied regurgitation, chest pain, dysphagia, cough, or dyspnea. She had the result of endoscopy that showed grade Los Angeles classification grade A esophagitis, and without hiatal hernia and gastric polyps. And she was, in that time, not using PPI for a long time. This is the result of the high-resolution manometry that was normal by the Chicago classification. And here I can call your attention for some metrics. She had a type 1 morphology of the esophageal gastric junction with normal resting pressure of the lower esophageal sphincter by 3 metrics, and esophageal barrier with excellent contractile vigor, DCI above 1000. This is the image of the esophagogastric junction at rest. And this is the image of the dynamics of swelling of this patient. We did a pH metry tool that shows that this patient has exposure at total time about 6, and the Mr. 25.3. And this is the image of the pH metry. Here we have 2 questions. Preoperative findings are decisive in helping to choose the best technique in these patients. What's the choice would we make for this patient? This is a work presented at SAGE 2019, shows a chart that tries to organize the reasoning of these cases. And here, this work suggests that we need to ask the patient if she wants to do, or the patient wants to do a sleeve gastrectomy, and if has symptoms of reflux, if the patients with mild or infrequent symptoms with PPI dependency or a normal esophagogastric endoscopy or esophagogram, the sleeve gastrectomy was deemed permissible. But if we have many symptoms, if the patient has pH testing or high-resolution manometry alterated, the patient must be recommended to Roux-en-Y gastric bypass. But this patient did sleeve gastrectomy, delayed it, and then returned to last month to our digestive motility service, showing great weight loss, but complaining about worsening of the symptoms of the GERD. She reported worsening of heartburn, regurgitation, clearing throat, and sometimes she has trouble swallowing solid and dry food. And she mentions that there has been a worsening of quality of life despite weight loss, and says that the surgeon suggested that maybe she had to do a reoperation to a conversion to a bypass. I apologize by the quality of this endoscopy, but this is the endoscopy of after the surgery, and she has in the description of the report a grade B esophagitis and a hiatal hernia. This is the results of the high resolution manometry, and now 2 years late, we can see a decrease of the lower esophageal sphincter pressure, a type 3 morphology of the AGJ, a decrease of the DCI, and afterwards we have 40 swells that are ineffective. This is the image of the AGJ after surgery, and this is the image of the esophageal barrier of this patient last month. We did multiple rapid swallows, 3 samples, and she has an increase of the DCI numbers, what shows that she has a contractile reserve preserved. Something very interesting is that when we do provocative tests with multiple rapid swallows, we usually do it to testing the DCI, the reserve contractile. But when we do this, we are trying to simulate a situation of a real life, the way that the patient do the swallows. And when we do this, in this kind of patients, we have sometimes an intragastric pressure elevated that we can see in this sample of the multiple rapid swallows. I think it's better when you do this with the patient in a upright position. And sometimes if you can do it with not just liquid, but solid, it's very, very interesting, very interesting. Why is easier, why is hiatal hernia occur easier, it's easier to happen after sleeve gastrectomy. The stomach is transformed into a tube of high pressure and low complacency, and the east angle is undone. This is the GEPH impedance monitoring of this patient, and we have worsening of the demister and the fraction total time, exposure total time, acid exposure total time. And we have many symptoms that are related with the acid reflux. Besides, we have an elevation of reflux that occur no acid reflux too, and we have here mean nocturnal basal impedance below 2000. This is the image of the impedance monitor of this patient. Here, acid and no-acid reflux. And in this image, we have a long duration drop of the line of the pH, and what we call the re-reflux situations, that the patient trying to clearance the esophagus with some regurgitation, some swells. The other questions I want to do is, what's the frequent manometric finds after sleeve gastrectomy? There are applicability to provocative tests in these cases. And if there is a difference in performing pH metry and pH impedance in evaluation of gastroesophageal reflux post-sleeve gastrectomy. Thank you.
Thank you very much, Carla, for this case. I would like to ask Professor Ghoshal if he could discuss this case.
I think it was a very interesting patient, but the patient, the physiology that happened after the surgery is not entirely unexpected, because once, as you said, that stomach's capacity is reduced, then obviously the esophagus is affected. Not only that, during the surgery, there is a possibility of the damage to the nerve. Therefore, the relaxation of the fundus, which is mediated primarily by the vagus nerve, may also get impaired, and that may lead to reflux and some changes in the motility. So what is your thought about this, that could there be changes in the nerve supply to the fundus and therefore fundic relaxation, and the capacity of the stomach which got reduced, leading to increase in the intragastric pressure during multiple rapid swallow, and therefore that could have led to change in the esophageal manometry parameter following the surgery?
Thank you very much, Professor Ghoshal. Carla, do you want to discuss the comments of
Yeah.
the Professor Ghoshal?
Yes. We have frequently seen these alterations in patients post-operative gastric sleeve gastrectomy, and the situation is that sometimes we see intragastric pressure elevated, and sometimes we not. Maybe 50% of these patients have intragastric pressure elevated. I think the provocative test is a good way to test these patients and intragastric pressure in these patients. And sometimes we observe the elevation of the acid exposure total time, but it's not so hard. And when we have the intragastric pressure associated with motility, ineffective swallows, we have pH metry and Impedance-pH metry that are worse and with elevated numbers.
Thank you, Carla. Professor Daniel, do you want to discuss about this case? I know you have studies with the patients before the bariatric surgery, and it's very interesting the results about the esophagitis, the prevalence of esophagitis in this case.
Yes, I have two comments. The first is that this patient should have never had sleeve gastrectomy, having reflux disease preoperative. It is well known and published that patients with reflux symptoms and or endoscopy or pH metry positive will respond very badly to sleeve gastrectomy. So I disagree with the algorithm that was presented justifying the sleeve gastrectomy. This is not a patient for a sleeve gastrectomy. The second issue that I wanted to mention, which is not exactly related to this case, but I find fascinating, is that obese patients have hyposensitivity in the esophagus. They are like Barrett patients. They do not feel very much acid in the esophagus. So there are many patients that get bariatric surgery without being objectively studied for reflux disease, just based on a symptomatic questionnaire. They don't have heartburn, they don't have regurgitation, and they get a bariatric surgery, and thereafter there are the disasters coming. So one thing that I would like to stress is that every patient that goes to bariatric surgery should have an objective exclusion of pathological reflux preoperative. It's not enough, the absence of heartburn. And finally, concerning the intragastric pressure and the effect on the reflux, I am not surprised. The patients still have transient LES relaxations, with a increased intrafundus pressure will always be associated with acid reflux. So I think that the scenario is set to get not only acid reflux, but these are in general young patients that they have 20, 30, 40 years ahead, and the risk of Barrett cancer is there. So what are you going to do with this patient now? The question of transforming the surgery and stopping reflux is not a theoretical or hypothetical question. It's a danger to have a patient with such a amount of reflux for the next 30 years. So this patient needs to be reoperated, whatever you want to do, if a Roux-en-Y or a hernioplasty or whatever, to stop reflux.
Thank you, Daniel. Carla, do you want to discuss more?
No,
Some
I
other
agree.
points
I
about
agree
this?
completely with Professor Daniel, and I think this is true. What we have to do with these patients need to be evaluated preoperatively and do a well evaluation, not by symptoms only. They need to do exams and we need to stop this reflux. So we have to do to give a solution to these patients. I agree, these patients that didn't need to do don't have to do a sleeve gastrectomy. Sorry.